All right. Good afternoon. I'm Tom Shimabukuro. I'm with the Immunization Safety Office and the Vaccine Safety Team on the Vaccine Planning Unit. And this afternoon, I'm going to be giving you an overview of vaccine safety monitoring. I'll cover some of the basic issues, and then I'll touch on some of our plans and some of our systems and some of our populations. And I just want to mention that I'm presenting on behalf of our partners, FDA, DoD, Indian Health Service, and VA. Next slide. So this is a schematic that's actually posted on the CDC website, and it describes the vaccine life cycle. This describes the traditional pathway, but I think the concepts are also relevant. And safety is a priority during all phases of vaccine development, approval, and use. We start off with basic research, discovery, preclinical work, and then move to the phased clinical trials. Once the phase 3 is completed, BLA is submitted, FDA reviews, and there's an approval, and shortly thereafter, there's an ACIP review and a recommendation, and then we move into what's called phase 4. Traditionally, CDC and FDA do most of the safety monitoring. There are other federal partners that participate in this monitoring, and monitoring for COVID vaccine will be a coordinated effort by multiple federal agencies. Next slide. So I just want to mention the rationale for post-licensure, post-authorization safety monitoring. So the safety standards for vaccines are high. Vaccines are for primary prevention. They're being given to generally healthy people, at least people who do not have the disease, so it's not for treatment. And therefore, the tolerability for risk is lower than, say, for drugs or for other things that are used to treat illness. Furthermore, the pre-licensure trials are not optimal for detecting rare adverse events. The numbers enrolled are too small, even with large clinical trials like the ones for COVID, where you have 30,000 individuals. They're not optimal for monitoring vaccine safety in a real-world environment. For assessing safety in special populations, often there are groups like pregnant women and individuals with certain pre-existing medical conditions are excluded, or at least excluded in the initial clinical trials. And then finally, evaluating adverse events with delayed onset. I think, as you heard previously, for some potential adverse events like vaccine-enhanced disease, I mean, they have to monitor out months to possibly years. Next slide. So I want to touch on the roles and responsibilities in vaccine safety monitoring, and there are really two players here. There's the manufacturers, and there's the U.S. government. The vaccine safety monitoring, as far as government, is really a federal responsibility. So next slide. So manufacturers have phase 4 responsibilities for their individual products. These are based on standard regulatory obligations as specified by the FDA. They can be guided by results from the clinical trials. They're conducted or managed by the manufacturer's pharmacovigilance programs with regulatory oversight by FDA. They may include post-marketing commitments, post-marketing requirements, and pregnancy registries. It also includes adverse event monitoring and reporting of adverse events to the Vaccine Adverse Event Reporting System. Next slide. The U.S. government has a responsibility for public safety, and many of these requirements are laid out in the 1986 National Childhood Vaccine Injury Act, which authorized the creation of the Vaccine Adverse Event Reporting System, which I'll touch on later. So U.S. government monitoring is independent from the manufacturers. There's no financial stake. There's less real or perceived conflict of interest. And this type of monitoring is important for public confidence. Monitoring covers all vaccines from all manufacturers in a comprehensive and integrated fashion. And the U.S. government manages large data systems that are standing long-term investments in public health surveillance. like VAERS, the Vaccine Safety Data Link, and CMS, all of which I'll cover in a little bit. And then finally, surveillance data from VAERS are made publicly available. This is available online to anyone. And surveillance findings from Phase 4 monitoring by the government are presented at Federal Advisory Committee meetings in a transparent manner. Next slide. So manufacturers play a critical role in post-authorization safety monitoring. However, we can't get all the answers from manufacturing monitoring. The U.S. government maintains and has constant access to the largest, most robust, and most sophisticated electronic monitoring systems available. And the systems and methods that we use are complementary. Government agencies can freely cooperate and collaborate, share information, leverage expertise in other agencies, and support each other's surveillance efforts, and can really act in a coordinated and integrated way. Next slide. I'll get into our safety monitoring systems and populations. Next slide. The first system I'll touch upon, I'm sure you're all familiar with, is the Vaccine Adverse Event Reporting System. This is our national spontaneous reporting system that's co-managed by CDC and the FDA. Next slide. So VAERS essentially has the entire U.S. population under as a covered population, all 320 million or so U.S. residents. This includes individuals of all ages, races, from all states, territories, healthy people, and those with comorbidities. In recent years, VAERS has received around 60,000 reports per year with a small number of foreign reports, most U.S. reports, and that averages out to about 1,000 reports per week. Next slide. So specifically focusing on older adults, I want to talk about some of the active surveillance systems in the U.S. government's arsenal. I'll start off with the FDA's Centers for Medicaid and Medicare Services data monitoring. This data monitoring system includes 55 to 60 million persons 65 and older, and this is about 92% of the U.S. older adults. The CDC's Vaccine Safety Data Link is a collaboration between 8 integrated healthcare systems, and this has data on about 1.8 million persons 65 years and older per year. And then the VA Data Warehouse and Electronic Health Record has about 1.56 million persons 65 years and older who are typically vaccinated for flu, and we anticipate would be a priority group for the VA. So these are EHR-based or claims-based or encounter-based systems, which we do active surveillance. So we have complete or near complete information, depending on the system, on a population. Therefore, we can calculate rates and assess risk. Next slide. Moving into the age group of adults and children, and I'm just to reinforce, CDC's Vaccine Safety Data Link has 8 million persons in the age of 19 to 64 years old and 2.3 million persons under 18 years old. And again, we routinely conduct active surveillance in the Vaccine Safety Data Link each season for flu, and when new vaccines are recommended, licensed, and recommended for use. Next slide. So I want to touch on a couple of FDA's systems that cover adults and children. First is FDA's Biologics Effectiveness and Safety System, or BEST. That has data from claims, EHR systems, and the FDA's Post-Licensure Rapid Immunization Safety Monitoring Program, or PRISM. That's part of the FDA Sentinel program, and that has EHR data from large health insurers with claims data and access to medical charts on about 100 million persons. Next slide. Some of the populations of our partners, our federal partners. The Department of Defense does VAERS monitoring in collaboration with CDC through a VAERS data sharing agreement. There's roughly 1.4 million active duty and 860,000 reserves, the majority of which are less than 30 years old. But this also includes dependents and beneficiaries if seen in DoD healthcare facilities. DoD also has the capability or the capacity to do active surveillance. And for COVID, the DoD Immunization Healthcare Division plans to collaborate with the Armed Forces Health Surveillance Division to monitor safety in DoD EHR systems, and is mainly using the Defense Medical Surveillance System and the DoD Personnel and Readiness COVID Registry. Next slide. Lastly, I want to mention a new collaboration between CDC and the Indian Health Service. We're currently entering into a VAERS data monitoring collaboration through a VAERS data sharing agreement. And the IHS population is mainly American Indian and Alaska Native patients seen in IHS and tribal healthcare facilities. We are working with IHS to identify reports in their patient population for individuals vaccinated in their facilities, and the analysis for the IHS data will be conducted by the National Pharmacy and Therapeutics Committee and the IHS Division of Epidemiology. Next slide. So I want to touch on case review and inquiry response. This is also a component of our monitoring and surveillance. Next slide. But it also provides a service to providers and individuals who have questions or concerns about vaccine safety. So the first system I'll mention is CDC's Clinical Immunization Safety Assessment Project, and the CISA project assists U.S. healthcare providers with complex vaccine safety questions about their patients by conducting in-depth clinical case reviews. And CISA also plans to establish a call service for clinician assistance during the COVID response. CDC's Immunization Safety Office manages an inquiry response program, and we respond to vaccine safety inquiries and questions from the public, including patients, parents, healthcare providers, and public health partners and others. And DoD runs a couple of services, the regional vaccine safety hubs for case evaluation and the vaccine adverse event clinical system. And DoD, through these systems, evaluates and tracks cases of adverse events following immunization in DoD and DoD-affiliated populations. Next slide. So I want to touch on some new initiatives for enhanced monitoring programs to meet the challenge of COVID-19. Next slide. So one of the challenges we've identified is that during the early phase of a national COVID-19 vaccination program, the initial doses may be distributed to specific groups such as healthcare personnel and other essential workers. And in this scenario, activities to enhance normal public health monitoring systems will be necessary. So potential solutions to address this challenge include active surveillance in early recipients through smartphone and email-based web surveys with directed reporting to VAERS for clinically important or clinically significant adverse events. This is really a combination of active surveillance for reactogenicity and then enhanced passive surveillance as well. And also vaccination capture and enhanced passive surveillance through other data sources from healthcare facilities with partners within CDC and other government agencies. Next slide. I just want to outline our current plan to conduct smartphone-based monitoring in early recipients of COVID vaccine. And again, this is in the scenario where there may be limited amounts of vaccine doses available, and those would be prioritized or delivered to certain workers like healthcare workers and other essential workers. So CDC currently is establishing a program to identify these potential early recipients of vaccine and to register them in anticipation of scheduling vaccination, getting vaccination, and communicating with them during vaccination, such as reminder recall. We plan to piggyback on this process to send text messages really starting right when they get vaccination, frequently early on to assess reactogenicity, and also to ask some specific questions, both in the first week or so and out to 6 weeks, about any clinically important adverse health events that the individual feels may be related to vaccination, depending on the answers to these text messages, which can either be through a text or through a web-based survey or through an email survey. We would direct these individuals to report medically important adverse events to VAERS, which ultimately get sent to CDC and FDA through the normal VAERS process. So through this, we would actually have both numerator and denominator data on these early recipients, and we think this will be a good way to early on characterize the basic safety profile of COVID vaccines in a real-world environment. Next slide. So other potential data sources to assist with vaccine safety monitoring include state immunization information systems to capture denominator data for adverse event rates. We are looking at capturing information on telehealth encounters and CDC's vaccine safety data link. We understand with COVID-19, there has been a fundamental change in the way healthcare encounters occur, and we want to make sure that we are able to capture data to the extent possible from these telehealth encounters in our surveillance systems. We also are able to gauge healthcare provider and general public concerns through our CISA inquiries and through our vaccine safety inquiry response program, which I mentioned previously. We do conduct thematic analysis on what types of concerns providers have and what types of concerns the general public have, so we get an idea of, it's kind of a pulse check out there on what the public thinks about vaccine safety and what concerns are rising to the top. And also our partners at FDA plan to develop new electronic data sources through EHR partners that they are working with. Next slide. So I want to quickly touch on signal detection and assessment. Next slide. So the SIOMS defines a signal as information from one or multiple sources which suggest a new potentially causal association or new aspect of a known association between an intervention and event or set of related events, either adverse or beneficial, that is judged to be of sufficient likelihood to justify verifactory action. For safety, we're really looking at adverse events, not beneficial events. Next slide. So I'm going to focus first on spontaneous reporting with a focus on VAERS. So there are traditional methods we use for signal detection and signal assessment. In VAERS, clinical review of individual reports is an important component of what we do. We plan to identify a select group of adverse events of special interest up front, but we review any report with any outcome, or we monitor all reports in VAERS. And the clinical reviews are really to verify the diagnosis and the onset interval, characterize clinical and laboratory features, and identify other potential risk factors. We also do aggregate report review in VAERS. That's really looking at automated data to get case counts, frequencies of adverse events, and reporting trends over time and reporting rates. We use statistical data mining methods in VAERS to detect disproportional reporting of specific vaccine adverse event combinations in the VAERS database. And the two methods we use are empirical Bayesian data mining, which is conducted by FDA, and proportional reporting ratio analysis. And these generate statistical signals when pre-specified thresholds are reached. And one of the first things we do when we detect a statistical signal is to go in and do this clinical review of individual reports, again, to verify the diagnosis, to check on the onset interval, look for biological plausibility, and to characterize the reports. Next slide. Timeliness for signal detection and assessment, of course, is important. And I just want to mention that CDC and FDA receive updated VAERS data sets daily. So on a daily basis, both CDC and FDA get what is essentially an updated version of the entire database because it's a dynamic database and it does update. And this is from the beginning until the current day, so 1990 all the way to the present. Each day we get an updated database from our VAERS contractor. The processing action for VAERS reports as they come in are a review and med-recoding of the symptoms. These are by certified med-recoders. There's also redaction of personally identifiable information. There's quality assurance, and there's preparation for posting on the secure VPN. These are individual reports that get posted on the secure VPN for investigator access. The processing times for COVID vaccines for death reports will be 1 day, for reports classified as serious within 3 days, and for reports classified as non-serious within 5 days. Next slide. So I want to touch on approaches for monitoring in EHR administrative and claims-based data. And when I talk about this, I'm really talking about near real-time sequential monitoring. And the example you're probably familiar with is rapid cycle analysis and the vaccine safety data link. So for rapid cycle analysis, the data are refreshed weekly in high volume situations. So a high volume situation that you're familiar with is influenza vaccine, where you have 100 or so million doses administered in the span of a couple months in the fall. In this case, we refresh the data every week. The pre-specified outcomes are monitored, so these are outcomes that are identified in advance. RCA is a surveillance activity. It's not the same as an epidemiologic study. It's designed to detect statistical signals, which are values above pre-specified statistical thresholds. When a statistical signal does occur, assessment requires a series of evaluations using traditional epidemiologic methods. Not all statistical signals are indicative of an increased risk or a vaccine safety problem. They need to be assessed. And chart confirmation and diagnosis to confirm or exclude cases as a true incident case is a key part of statistical signal assessment. I will say in VSD, our ability to pull the charts and review them is rapid. Typically, we can do a rapid review of a chart within 1 to 3 days. A more detailed chart analysis, which sometimes requires going out and getting additional information and applying case definitions, can generally be conducted within a week. So the statistical signal assessment process is fairly rapid. Next slide. Next slide. So in closing, I want to emphasize a few points, and I just got done talking about the timeliness, but I'll emphasize it again. Real-time or near real-time safety monitoring will be critical during the early stages of the COVID-19 vaccination program. And this is to characterize the safety profile of COVID-19 vaccines quickly in a real-world environment, and to rapidly assess COVID-19 vaccine safety in risk-based priority groups such as older adults and individuals with certain pre-existing health conditions. During a broad-based vaccination program, large amounts of COVID-19 vaccine are anticipated to be administered during a short period of time, and it's important to have established high-functioning systems and validated methods in place to rapidly detect and assess potential safety signals so public health action can be taken if necessary. Next slide. So I just want to briefly touch on process. So as you know, there is an ACIP COVID-19 vaccines work group that's chaired by Dr. Beth Bell. The mission of this group is really to advise on the planning and use of vaccines and advise on all components of program implementation during a large-scale COVID-19 immunization program. Also to review post-authorization or post-approval vaccine safety surveillance data. So there is a ACIP COVID-19 vaccine safety technical subgroup, which is a subgroup of the COVID work group that's chaired by Dr. Grace Lee. And the purpose of this technical subgroup is to advise on the safety of COVID-19 vaccine candidates in development, and safety monitoring of vaccines authorized or approved for use. And one of the key things we'll be doing during the implementation of a vaccination program is review post-authorization or post-approval vaccine safety surveillance data. Next slide. So to close, multiple U.S. government agencies will use complementary systems and methods to monitor COVID-19 vaccines. The current monitoring systems that I described have the capacity to effectively monitor COVID-19 vaccine safety both under EUA and in a post-licensure scenario. The analytic methods have been validated through years of development and refinement. Data refresh and updates are timely, and analysis occur in near real time. And new data sources will contribute to COVID-19 vaccine safety monitoring, especially early in the vaccination program. Next slide. I just want to preview a few topics for future presentations to ACIP. We plan to get into more detail on our COVID-19 vaccine safety monitoring plans and methods to include vaccine safety outcomes and adverse events of special interest for COVID monitoring, and also the process for reviewing and presenting safety data as it becomes available during the implementation of a program. That's my final slide, and I'm happy to take questions.
Thank you very much for that excellent presentation. Are there any questions or comments from the committee? Dr. Hunter, please.
Thanks for that helpful presentation. I'm just wondering if you can comment now or in future presentations about how often potential signals turn out to not be concerning or not be biologically plausible cause and effect relationships.
So I have in the past used a number that about 90% of statistical signals that we detect in our monitoring do not turn out to be true signals after assessment. I think that's somewhat arbitrary, but I will say that most of the signals we detect after we assess them, and like I said, that involves both doing a quality check on the actual data and assessing biological plausibility, most turn out to be not true signals.
Thank you. That's very helpful.
Dr. Paling.
Thank you for that fantastic presentation about all the complementary systems to detect and then verify things are safe. I wanted to ask a question about the active surveillance in early recipients, which is really exciting. And one of my questions is, as people are thinking about launching their flu vaccine campaigns, including in healthcare workers, is there any work towards testing the system and seeing how it works?
You mean testing it for
in
flu recipients?
Yeah,
for
so
flu?
You would do it, yeah, so that you know how the system works before before COVID starts.
I'd have to defer to the immunization program on the text monitoring part of that, because the safety component is piggybacking on the actual text monitoring. I will say for our other systems, I do think that there is an opportunity in some of our other data sources working with our other partners within CDC. There is an opportunity to do that. So some of the other, and I'll just mention NHSN is one of the systems that we're working with. I do think there's an opportunity to evaluate how well we're collecting vaccine exposure, and to also work on education and outreach on directing individuals who have adverse events or healthcare providers who evaluate them to report to VAERS. So I think there's an opportunity to do that.
Dr. Fry.
Thank you. Thanks for that great presentation. It was very interesting. I also had a question about the active surveillance in early COVID vaccine recipients and was curious to know how many individuals you anticipate following, and why you would choose a certain number of individuals, for example, so I can better understand whether you'll be capturing any SAEs, because we know we need to follow typically thousands, if not more, people to find some of the more the rarer complications. Thank you.
I believe the answer to that question is we would follow as many people as we are able to capture in the initial registration process for vaccination. So there isn't a limit. We're not saying we need to hit this many. I think we would the system is capable of sending text messages and implementing the online survey in as many people as we can send the messages out to. I do not believe there is a hard limit, and certainly for safety, we're not saying we need to meet this number and that would be good enough. We're interested in getting as much data on these early recipients as possible.
Dr. Hunter, I see that your hand is still up. Did you have a follow-up question?
No, sorry, I'll get it done.
Dr. Bernstein.
Yeah, thanks, Tom. This was a wonderful overview of a critically important process. I just had a question around the case reviews and inquiry response. You mentioned about planning to establish a call service for clinician assistance. Is that intended to be retrospective or prospective? What kinds of calls are you expecting, and what kind of availability will that be, 24/7 or otherwise?
It's intended to be prospective. If clinicians have vaccine safety questions, either specific or general or on topics, I'd have to get back to you on the coverage, but it's intended to be available as a service for clinicians as they need it if they have a vaccine safety question and want to talk to a CDC subject matter expert on vaccine safety.
And given the number of vaccines that are going to be or planned to be administered in such a short period of time, it will be a great service, I think, to clinicians at point of care.
Dr. Arthur.
Thank you very much. Actually, this piggybacks off of the last question asked. Great presentation. Thank you, Doctor. Will you be planning as part of the communication strategy for the rollout leading up to the vaccine to do educational activities for clinicians on the various safety monitoring systems? We found that many doctors don't necessarily understand how to use theirs, and it probably would be good, given how many immunizers there will be for the vaccine, to have some general education before launch on the various systems they should report to.
The short answer to that is yes, we plan to do outreach and education. I think for providers, it's largely around, as far as an active role that they can take, it's around VAERS, but certainly around educating healthcare providers on vaccine safety monitoring and how thorough the U.S. government is and how serious we take it and how transparent we want to be. So yes, we do plan to do education and outreach, both specific meaning what can you do or what can I do, and general as far as this is how we monitor vaccine safety.
Ms. McNally.
Thank you. Can you explain how you receive post-licensure safety monitoring information from the manufacturers, and also what the timing of that looks like?
So the post-licensure, most of the post-licensure safety monitoring data we receive from the manufacturers comes through VAERS. So the manufacturers are required by FDA to submit a report, a VAERS report, for any adverse event that comes to their attention. That reporting process goes through FDA, and then funnels into VAERS. As far as other phase 4 safety information that the manufacturers communicate to FDA, I'd have to defer to FDA. I can only really talk about adverse event reports. I know that there is a reporting requirement that any adverse event get ultimately reported to VAERS, so both CDC and FDA have access to those manufacturer reports.
Thank you.
Are there any additional comments on that from FDA?
It's fine if they're not. We just wanted to make sure you had an opportunity to speak.
No. So vaccine manufacturers are required to submit yearly safety reports to FDA that include safety data from spontaneous reports that they may receive from patients or healthcare providers, as well as results of post-marketing studies that they conduct, not just in the U.S., but also worldwide. And so FDA does review those reports and examines the data to inform any regulatory actions that we might take over.
Thank you, Dr. Fink. Are there any other questions or comments from the voting members? Very good. Thank you, Dr. Shimakuru. We will now go on to Dr. McClung for her presentation on epidemiology of individuals at increased risk for COVID-19 disease. Dr. McClung, go forward, please.
Good afternoon. Next slide. First, I'll present a brief update to the overall U.S. COVID-19 epidemiology, and then epidemiology among individuals at increased risk of severe COVID-19 disease, including older adults aged 65 years or older and adults with underlying medical conditions. Next slide. Next. As of August 23rd, a total of 5.6 million cases have been reported to CDC. This map shows the cumulative case counts by county, with the darker red representing larger number of cases. Next slide. This figure shows the trends in the number of COVID cases reported per day in the U.S. through August 23rd, with the 7-day moving average in red. Nationally, cases peaked in mid-July and have been decreasing over the past month. But daily case counts reported remain higher than what was seen before the increases in June. Next slide. This figure shows the number of specimens tested for SARS-CoV-2 using a molecular assay and reported to CDC by public health labs. The number of specimens tested are in the bar graphs, and the percent positives are shown on the line graphs. Nationally, the percentage of specimens testing positive for SARS-CoV-2 have continued to decrease since mid-July. In this past week, week 33, the overall percent positive at public health labs was 6.6%. Next slide. This figure shows the specimens tested and percent positive among commercial labs reporting to CDC. Note the x-axis is different from the previous slide, as the number tested at these labs is substantially higher. The percentage of specimens testing positive in commercial labs has also been decreasing since mid-July. And this past week, week 33, the percent positive was 6.3%. Next. As of August 23rd, a total of 176,223 deaths due to COVID-19 have been reported to CDC. This map shows the cumulative number of deaths by county, with the darker purple representing the larger number of deaths. Next slide. This figure shows the trends in the number of COVID deaths reported per day in the U.S., with the 7-day moving average, again in red. Nationally, the number of deaths peaked at the end of April, then declined through the end of June, began to increase again in July, and for the past month, the number of deaths has remained relatively stable at approximately 1,000 deaths per day. Next. Next. Adults aged 65 years and older and people of any age with certain underlying medical conditions are at increased risk for severe illness from COVID-19. Next. Severe illness is defined as hospitalization, need for ICU care, need for intubation, or death. Next. In the United States, older adults aged 65 years or older represent 16% of COVID-19 cases, shown in the green lines, but nearly 80% of COVID-19 deaths, shown in the blue lines. This figure shows case-level data reported by health departments to CDC for approximately 4.2 million cases and 131,000 deaths. Adults aged 65 years and older are highlighted in the red box, and as you can see, the percentage of deaths increases with age. Next. Much of the data I'll be presenting today comes from COVIDNet. I know that the committee has seen this slide several times, but I'm including it today for those that may be less familiar. COVIDNet conducts hospitalization surveillance with 14 states, representing about 10% of the US population. Patients must be a resident of the surveillance area and have a positive SARS-CoV test within 14 days prior to or during hospitalization. Chart reviews are conducted and data include underlying medical conditions. Next slide. Older adults aged 65 years and older have the highest cumulative rate of COVID-19 associated hospitalizations. This figure shows the cumulative rate of hospitalizations by week reported to COVIDNet. As of week 33, which is August 15th, hospitalization rate among older adults is almost 4 times the rate of adults aged 18 to 49 years. Next. This figure shows the percent of severe outcomes by age group in adults reported to COVIDNet through August 15th. Adults aged 50 years and older, seen in the black and blue bars, are more likely to have severe outcomes during hospitalization compared to adults aged 18 to 49 years in the gray bar. Of note, 25% of adults 65 years and older in blue died during hospitalization compared to 2 to 10% of the younger age groups. Next slide. Among 2,491 adults with COVID-19 associated hospitalizations reported to COVIDNet between March 1 and May 2, older age was the strongest independent risk factor for in-hospital death. This figure shows adjusted rate ratios and 95% confidence intervals from a multivariable model of risk of in-hospital death. And I will be coming back to this figure later in the presentation. As you can see in the red box, not only is age the strongest risk factor, the risk increases with increasing age. Hospitalized adults aged 85 years or older had 11 times the risk of in-hospital death compared to hospitalized 18 to 39-year-olds. Next slide. These data are from a recently published multi-center US cohort study including 65 hospitalizations across the United States. Among 2,215 adults with COVID-19 associated ICU admission between March 4 and April 4, older age was the strongest independent risk factor for in-hospital death within 28 days of admission, even after adjusting for patient and hospital level characteristics. Similar to COVIDNet findings, as you can see in the figure, with increasing age, the odds of in-hospital death increased. Adults 80 years and older admitted to the ICU had 11 times the odds of death compared to 18 to 39-year-olds admitted to the ICU. I will also be returning to this model later in the presentation. Next slide. Next. This figure shows COVIDNet data through August 15th for selected underlying medical conditions among adults aged 18 years or older with COVID-19 associated hospitalizations. Some conditions listed in this figure include multiple conditions. For instance, cardiovascular disease includes coronary artery disease and congestive heart failure, among other conditions. The most common underlying conditions here were hypertension, obesity, diabetes, and cardiovascular disease. Next. The most common underlying medical conditions seen in the previous slide among hospitalized adults varies by age group. You can see obesity in red was in the top 1 to 2 conditions reported for younger and middle-aged adults, but only reported in 34% of adults 65 and older. Hypertension in blue was the most common among middle-aged and 65 and older adults, and diabetes was a most common condition in all groups. Next. From COVIDnet, over 60% of hospitalized adults aged 18 years and older had 3 or more of the selected underlying medical conditions seen previously. Only 12% of hospitalized adults had no underlying medical condition. Next slide. This figure shows a number of conditions by outcome: death, need for mechanical ventilation, or ICU admission, with each outcome adding to 100%. Of hospitalized adults aged 65 years and older, nearly 80% had 3 or more medical conditions, and approximately 70% of adults requiring intubation or ICU admission. Next slide. This figure shows the same data by age group, with each age group adding to 100%. Of hospitalized adults 65 years or older, 80% had 3 or more underlying medical conditions versus 60% of 50 to 64-year-olds and less than 40% of 18 to 49-year-olds. Next slide. Although we know underlying medical conditions are common among hospitalized adults, are underlying medical conditions independently associated with COVID-19 associated hospitalizations among adults in the general population of 18 years and older? A recent analysis by the COVIDnet Investigations Group combined population-based data from COVIDnet and the Behavioral Risk Factor Surveillance System, or BRFSS, to answer this question. COVIDnet includes community-dwelling adults, that is, residents of the catchment area prior to their hospitalization, with chart-abstracted data on underlying medical conditions. The analysis included about 5,000 individuals hospitalized from March 1st to June 23rd. BRFSS is an annual cross-sectional survey on health behaviors and self-reported underlying medical conditions among community-dwelling adults or residents in all 50 states, DC, and 3 US territories. The data was weighted to be representative of the population residing in COVIDnet catchment area. Next slide. For the statistical analysis, prevalence of underlying medical conditions was calculated among the COVIDnet hospitalized adults, the COVIDnet catchment area, and nationwide. Unadjusted and adjusted rate ratios and 95% confidence intervals for hospitalization were calculated for each medical condition, and the models were adjusted for age, sex, and race and ethnicity. Next slide. The overall prevalence of underlying medical conditions was greater among COVID-19 hospitalized cases from COVIDnet, shown in the blue bars, compared to the COVIDnet catchment area, shown in the yellow bars, and the United States, shown in the orange bars. COVIDnet catchment area estimates were similar or slightly lower than nationwide estimates. Next slide. This figure shows adjusted rate ratios and 95% confidence intervals for hospitalization by medical condition. The magnitude of risk for hospitalization was greatest for adults with severe obesity, chronic kidney disease, and diabetes. Adults with these conditions had 3 to 4 times the risk for hospitalization compared to hospitalized adults without these conditions. Adults with hypertension and obesity had almost 3 times the risk for hospitalization compared to adults without those conditions. Next slide. The magnitude of risk for COVID-19 associated hospitalization was greatest for adults 65 years and older for all underlying medical conditions. And this table shows the same data as the previous slide, but by age group. And compared to adults aged 18 to 44 years, adults 64 and older had 2 to 4 times the risk of hospitalization, depending on the condition. And although of smaller magnitude, adults aged 45 to 64 also had an increased risk for hospitalization compared to the younger group for all conditions. Next slide. The magnitude of risk for hospitalization increased with the number of underlying medical conditions, with the greatest risk among adults with 3 or more conditions. This table shows the unadjusted and adjusted rate ratios for number of medical conditions and COVID-19 associated hospitalization. In the adjusted model, any number of conditions increased risk for hospitalization, but adults with 3 or more conditions had 5 times the risk compared to adults with no condition. Next slide. To summarize this analysis from COVIDNet and BRFSS, accounting for age, race, ethnicity, and sex, higher hospitalization rates were observed for adults with underlying medical conditions in the general population, adults of the COVIDNet catchment area. Adults with 3 or more medical conditions had the highest hospitalization risk, and certain conditions had higher risk as well, including severe obesity and chronic kidney disease, with almost 4 times the risk compared to adults without those conditions, and diabetes, obesity, and hypertension with 3 times the risk compared to adults without the condition. Also accounting for the presence of underlying medical conditions, higher hospitalization rates were observed in adults 65 years or older compared to younger age groups. Next slide. So the previous analysis focused on risk for hospitalization in the population, and now we are back to the previously shown COVIDNet multivariable model for risk of in-hospital death. The red box is now highlighting that in addition to age, certain underlying medical conditions were independent risk factors for in-hospital death, with each having 1.2 to 1.4 times the risk of death compared to hospitalized adults without those conditions. Next slide. And now coming back to the large multi-center US cohort study among adults with COVID-19 associated ICU admission shown previously, you can now see that in the same model, certain underlying medical conditions are also independent risk factors for death within 28 days of admission. Again, even after adjusting for patient and hospital level characteristics. The odds of death after ICU admission increased 1.5 to 2.2 times for individuals with severe obesity, BMI greater than 40, coronary artery disease, a cardiovascular condition, and active cancer. Next slide. This figure shows data on number of underlying medical conditions among COVID-19 deaths reported by supplementary US case-based surveillance data that's reported to CDC. This is different from COVIDNet surveillance. Among convenient sample of about 10,000 COVID-19 deaths that occurred from February 12th through April 24th by 16 health jurisdictions, 76% of decedents had at least one underlying medical condition, and the majority of decedents of any age had multiple conditions, including adults less than 65 years, shown in gray, and adults 65 years or older, shown in blue. Overall, the most common underlying conditions reported in this group were cardiovascular disease, diabetes, chronic kidney disease, and chronic lung disease. Next slide. So in addition to COVID-19 surveillance of severe COVID-19 disease, CDC has an ongoing evidence-informed process to assess the risk for severe COVID-19 disease for individuals with underlying medical conditions. This includes a comprehensive ongoing literature review on underlying conditions with an internal database to track both published peer-reviewed and preprint articles, collaboration with subject matter experts across the agency, and monthly updates to the CDC website, which is listed at the bottom of this slide. Next slide. The list of underlying conditions is organized in 2 tiers based on the level of evidence. The conditions that are considered associated with increased risk are informed by strong evidence, defined as consistent evidence coming from multiple smaller studies, or a strong association from a larger study. Conditions listed in the second tier might be associated with increased risk, are informed by mixed or limited evidence. Mixed evidence is defined as multiple studies that reach different conclusions, and limited evidence is considered that from which a small number of small reports. Specific evidence for each condition is on the CDC website. Next slide. This is CDC's list of conditions that are considered associated with increased risk for severe disease. They're listed alphabetically and include cancer, chronic kidney disease, COPD, an immunocompromised state from solid organ transplant, obesity, serious heart conditions, sickle cell disease, and type 2 diabetes. Next slide. This is a list of conditions that might be associated with increased risk for severe disease. These conditions are also listed alphabetically and include asthma, cerebrovascular disease, hypertension, and a number of other conditions that you can see listed here. Next slide. Of note, nationally, 41% of adults in the United States have at least one underlying medical condition that puts them at risk for severe COVID-19 disease. By county, the prevalence varies from almost 1 in 4 to as many as 2/3 of adults having at least one underlying medical condition. In half of US counties, almost 50% of adults are estimated to have an underlying medical condition, as you can see in the figure on the slide. Next. In summary, as of August 23rd, over 5.6 million cases of COVID-19 have been diagnosed, and over 176,000 COVID-19 associated deaths have been reported in the United States. Older adults aged 65 years or older have the highest risk of severe COVID-19 disease, and within this age group, risk increases with increasing age. Adults with underlying medical conditions also are at increased risk for severe COVID-19 disease. Obesity, diabetes, and cardiovascular disease are common conditions observed across data sources. And of importance, multimorbidity increases risk of severe COVID-19 disease. Surveillance and projects are ongoing to continue to monitor COVID-19 associated hospitalizations and death, and to identify persons at higher risk for severe COVID-19 disease. Next slide. I'd like to take a moment to acknowledge the contribution of the COVIDNet hospitalization surveillance team and the Community Interventions and Critical Population Task Force that helped with these slides today. Thank you.
Thank you, Dr. McClung. This is now open for questions or for discussion. Any questions from the members? I'm not seeing any. I think it's a tribute to your excellent presentation. Sorry, my mask. Oh, wait, spoke too soon. Dr. Gluckman, please go forward. Dr. Gluckman? Grace? Dr. Lee? Oh.
The data that you showed about the patterns of mechanical ventilation from March through August. One question I had is, are you noticing some shift in the use of mechanical ventilation and the frequency of that, since it appears that that may actually increase the risk of mortality? And my second question is, in your presentation, you kind of demonstrated that there's a lesser relationship between the presence of chronic conditions in young people who have serious COVID. And is there any hypotheses as to why that might be less of a factor in young people?
This is Sarah Oliver. Could you repeat the second question? I apologize that we just didn't quite catch that one.
Sure. When you demonstrated the correlation between the presence of chronic conditions and severe COVID, you showed a significant increase in older patients, but in younger patients, it seemed like a higher proportion, or many of those patients had either one or two chronic conditions or none. So do you have any hypotheses about why some young people may develop serious COVID without coexisting chronic conditions?
Thanks. So regarding the first question, COVIDNet doesn't specifically look at kind of an association with ventilation and death. And so I don't know that we can use that data to comment on that. Regarding the second question, I think it probably just has more to do with the fact that the younger population just is generally healthier and we showed that they're less likely to have that multimorbidity as opposed to the older population. So I think it's likely an interplay with a younger, healthier population as a whole that we're seeing there.
Dr. Lee, please.
Thank you. I just had, it's actually a minor question, which is just for the 41% estimate of greater than one medical condition. I might have missed it, but does that include the 2 slides that show the risk factors that are associated versus might be associated? Are both included?
That's a good question. This is Nancy. I think those only include the ones that are associated with COVID-19 disease, but we will check on that.
Dr. Messonnier wants to add comment.
No, actually, I was going to ask a question.
Go ahead.
Hi. 2 questions, maybe. One, does COVIDNet have data on treatment, and are you able to correct for sort of treatments that might also be having an impact on outcome? And second, are there other data from other countries that are finding the same things and can sort of corroborate our findings here in terms of the trends that you found?
Sure, I can comment on the global question. So there has been recently published a global meta-analysis on comorbidities and mortality, and the findings are similar to what we are seeing in the United States.
And we can make that paper available. And then Shika, are you on the line to comment a little bit more about the COVIDNet treatment and the extent to which you guys have that?
Can you hear me?
Yes, we can. Great, thanks.
So we do collect data on treatments in COVIDNet. We collect data on remdesivir, convalescent plasma, and other medications. We've been adapting that as the pandemic has been evolving, and we have another field, and so we continue to collect new and emerging treatments. We haven't yet thought through methods for specifically looking at the impact of treatments on outcomes. I think that's something we're interested in looking at in the future. One, we're still collecting data, so we don't have complete treatment data on all cases. And then 2, just thinking through the biases about who's receiving treatment versus who's not. I think we need to think through that before we do that analysis.
Thanks, Shika.
Thank you. Dr. Bell.
Thank you. I just have sort of a general technical question about COVIDNet, which is the extent to which data in COVIDNet can be disaggregated according to evaluate kind of regional differences in some of these outcomes that we're looking at.
Yeah, I'll comment first and then see if Shika has anything to add. But I do know that it's across a geographically diverse, so it's 10 study sites, but it's a geographically kind of spread across the U.S., representing about 10% of the U.S. population. And the BRFS data was matched to the same communities as, the COVIDNet catchment areas. Shika, do you have anything else to say?
Sure. I'll just add that there are 4 additional sites. So we have select counties, about 99 counties across the 14 states. We haven't done specific state-by-state analyses. We could potentially try to group some regions together and do those types of analyses, but we haven't done that yet.
Thank you.
Dr. Bernstein.
Yes, thank you. You may have said this, I may have missed it, but on the COVIDNet hospitalization surveillance team, what are the plans for pediatric population under the age of 18?
This is Nancy. COVIDnet surveillance does capture all COVID-19 associated hospitalizations in all ages, and that data is publicly available. I did not present data on children today, but it is available.
Thank you.
Are there any other questions or comments from the voting members? Seeing none, we're scheduled for a break until 20 till, but I think what we'll do is we'll go into, we'll give you 12 minutes and say start at 10 till.